there's really no preparation of the site. They do that in the actual OR. But the main thing is when they come back to you after PACU, what do you think is the primary nursing care that you have to watch for? Bleeding. Bleeding at the site. They put a compression device on either the hip or the tibia. Make sure that compression device for the bandage is kept in place for at least 72 to 48 hours. And you follow the practitioner's orders to the T on that. A lot of times these practitioners like to take that first dressing off themselves, and they usually write that, so you don't mess with the dressing. Your main concern is you're washing the dressing, make sure there's no bleeding. If there is excessive bleeding, that the bandage is now flowed through, you need to call the practitioner. Let's apply pressure on the site and call the practitioner and notify them of the bleeding. So bone marrow aspirations are really done if we're having issues that several of the white blood cell or red blood cell count, platelets, we're seeing abnormalities across the board out front of you and not really sure what's going on. So then a bone marrow aspiration may be done. All right, talk about anemia. Anemia. I'm going to go pretty quickly on the condition. Anemia you do need to know. In general, what does anemia mean? In general. There's a lot of different types of anemia. Okay, so anemia in general is a decrease in the amount of RBC, red blood cells, which means then the ability to carry oxygen is then affected. Why is that? Okay. RBCs have the hemoglobin, right? The protein that actually carries oxygen. And the other thing is it also carries iron. Okay? So in children, a lot of times when their RBCs are low, they may also have iron deficiency anemia. Okay? But in general, anemia means a decrease in RBC, therefore a decrease in the ability to be able to carry oxygen. What can cause anemia? Well, there's a variety of reasons. There's a variety of reasons that can cause anemia, right? So when we look at increase in RBC loss, what are some examples when a child may lose blood quickly? Injury, trauma, a gunshot wound, accident, and they lose blood quickly, so they're losing RBCs quickly, and guess what happens? They go into anemia. Okay? Increased destruction of RBCs. What's an example of that? That's already that we're going to cover today. Sickle cell anemia. That's a classic case in children where you have a destruction in RBCs. All right, so you have these abnormal RBC sickle cells, and therefore they can't go through these small vessels, and therefore it gets kind of clumped there, and it destroys, and it breaks down much faster than a normal RBC. What about decrease in RBC production? Okay, so bone marrow disorders, renal, somebody said renal, right? We talked about last week when there is no production of epigen, right? You got a decrease in production of RBC. So it could actually be something wrong with the bone marrow. Certain cancers can cause that, and then also maybe kidney or other functions, other issues that will be there. All right, so overall, you have decreased oxygen carrying capacity. We already said first, blood carries oxygen and every cell needs oxygen, correct? And so when you don't have enough oxygen in circulation, then there's decreased oxygen that's available to the tissue overall. Okay, so less in circulation, therefore less available in circulation. It says cyanosis is typically not evident. What do we usually see in patients with anemia? Pallor. Okay? It's not that they are anemic and they're cyanotic. A lot of times you don't. Many times this is a slow process. And so your body tries to adjust. So what we see most often in children, they look very pale, pallor. Okay? And then if that continues, growth retardation. So if they have anemia for a prolonged period of time, decreased oxygen to those tissues, vital organs and tissues, muscles, guess what? Overall growth is going to be affected in these kids. So growth retardation, delayed sexual maturation in older children, so as they get into adolescence, pre-adolescence, adolescence, and into young adulthood, there's going to be significant delay in sexual maturation. So when we talk about anemia, we're talking about hemoglobin that's less than 10 to 11 in children. Okay? So remember I told you, know your ranges, normal ranges for all of your blood cells. So what do we see in the child? What does the child look like? They're energetic, ready to play, they come home from school and they're all over the place. What concerns do we get from parents? They're tired. They're tired all the time. They seem to get enough sleep at night, but they're so tired during the day. They can't stay awake long enough in class, and so their grades are affected. So overall muscle weakness, easily tired, frequent rest are needed. In your infants who are not able to tell you that they're tired, what do you see? Poor sucking. Because what happens when the child is sucking? The oxygen demand increases, right? And the body's not able to sufficiently get oxygen to the system. And so for sucking, the child is tired quickly, pale skin, and then overall failure to thrive. Failure to thrive is a term that's used to where the child is not meeting their milestones, but especially in growth and weight. Failure to thrive. Okay? Children, pica. What's pica? Okay? Non-nutritive substances. Non-nutritive substances. Ice. Ice. If you have a child that's chewing on ice constantly, it's a good indication that the primarily iron deficiency. Okay? I still remember a parent that came in and recognized definitely something was wrong, brought in the child's notebook that they used for school, and all of the edges had been chewed off. Paper, notebook, right? Soil, eating, when they're at the park, they're eating the soil from the park. That's examples of pica. Eating non-nutritive substances, and most often it's iron deficiency anemia. So they're craving non-nutritive substances like ice and things like that, and they feel like they need to chew on something, usually iron deficiency anemia. So overall lack of energy, pallor, fatigue, heart murmur. Why do you think they have a heart murmur? Or what do you think is going on with their heart? Is the heart rate higher or lower? Higher. Heart rate is higher. Why? Okay. So it's trying to meet the oxygen demand that the body needs, and it's going to increase heart rate. And unfortunately, some of your younger kids are going to have what's called a murmur. Murmur is, Professor Rich went over this. Murmur is when you hear that extra vibration in the chambers of the heart, when it's large enough murmur. Usually children should not, but when you have increase in heart rate, children have fever, they're tired, sometimes you can hear that. Or when they have a cardiac arrest, you can hear the murmur. Okay? And that's some of the early indications that something is going on with the child. All right, these are some of the etiologies. Read through that. And so the goal is to really find out what's causing the problem and take care of that very quickly. So one of the conditions where anemia develops in children is iron deficiency anemia. Okay. So basically iron deficiency, there's decreased or inadequate supply of iron that is needed in the hemoglobin in order to be able to transport oxygen readily. Okay. Where do we see iron deficiency anemia the most? Well, in infants, usually about after 6 months. Why not too much before then? Okay, good. So if they're term, not necessarily breastfeeding, if they are term gestation, that means they are about 9 months in pregnancy. During that last trimester, there's iron stored that the child gets from maternal circulation. Okay, so the iron is stored adequately in the child so that the child has adequate iron for about 5 to 6 months. If you have a premature child, someone who's born premature, so maybe 24 weeks, 30 weeks, 32 weeks maybe, their adequate storage of that iron may be less. Okay? Or multiple births. They have twins, triplets, etc. They may not have as much iron. So where we really see iron deficiency is usually around 6 months or after. Okay? And then the other period that we see most is in adolescence. A lot of them, they started their menses, but they're not taking in adequate nutrition, and therefore they're losing blood and volume, and therefore, they end up having iron deficiency anemia. So those are the two major groups that we see iron deficiency. So I just went over that. So in your children, about 12 months of age, we tell parents to transition from formula breast milk into iron fortified milk. Okay, right? Cow's milk, regular milk. So what happens a lot of times is the kids are drinking milk, but they're drinking a lot of milk. Sometimes it's a comfort mechanism. Give them a bottle of milk, and the children get calm and they're quiet, don't bother the parents. But sometimes they're drinking a lot of milk, and they're not hungry, and they're not eating other nutrients that have iron in it. Okay? So the current recommendation is about 3 to 4 cups of milk per day, and that's it in your toddlers and preschoolers, etc. Okay? So they should be practitioners usually recommend for parents to give them food first, so that they get full on the food, and then give the milk at the end. Okay? And so that they're not filling up on the milk and not getting the nutrients. Oh, the other reason, let me mention this as well. It says 50% of non-deficient infants. So formula costs a lot of money. Those of you have kids in here, you guys know that, right? Formula costs a lot of money, and so parents may start them on whole milk early because it's cheaper. And whole milk has larger proteins that the stomach cannot digest, and so it ends up causing them bleeding in the digestive tract, and so they end up having fecal blood, digestive irritation, inflammation, because they're introduced to these large milk proteins before their stomach can actually handle it. Okay? And that's when we also see iron deficiency. So now there's blood loss from these large proteins. Alright, so one of the first things we do with iron deficiency anemia is really dietary changes. Okay? So somebody mentioned cereal. Most of your cereals are iron fortified, right? But this is really interesting. Iron is really poorly absorbed in milk. So most of the time when we eat cereal, what do? A bowl of milk, right? And so what happens is a lot of that iron gets attached to the calcium in the milk and other minerals, and it basically just goes right through the digestive tract. It doesn't get absorbed into the GI tract. So ideally, if they have iron fortified cereal, they should have it with some apple juice, orange juice. Trying to get your kids to do that, good luck. Okay? Because the iron is absorbed in what environment? Vitamin C. When there's a lot of vitamin C in the environment, iron is readily absorbed into the GI tract. So we tell them to take iron with a little bit of apple juice or orange juice. But if you try to do that with cereal, kids are not going to do it. And what's the other source of iron? What's the other source of iron? Make sure you know that. NCLEX always, that's a really good question.
Leafy green.
What is it? Spinach, green leafy vegetables, broccoli. We love getting the kids to eat that, right? There's some kids that will gobble all that up really quickly, but most of the time they have a hard time. What else? Iron, good sources of iron. Organ. You heard of liver and onion? Okay. When I was young, I had anemia, and guess what? My parents made liver. I've been traumatized by it. So can you imagine trying to give, recommend that to parents to give to their kids? It's a great source of iron because it's very vascular, like we talked about, liver. Okay. So organ meat, because they do have a lot of hemoglobin and iron in it. So we try that for maybe a couple of months, and then we have the child come back and we'll do another panel of labs, including hemoglobin, iron, etc. If that's not quite working, then they put them on iron supplements. But if the child comes in and they're already chewing on the notebook, or their teeth look like it's, the enamel is coming off because they're chewing on a lot of ice, then guess what? We're not waiting a couple of months. They're going to be on supplements of iron. So ferrous sulfate, usually in children, young children, it's going to be in liquid form. When the liquid is given, we tell parents to give it with a little bit of apple juice or orange juice so that it absorbs better in the GI tract. If they can give it on an empty stomach, that's better. Most of the time, the children are gagging and choking as they give it to them, right? And we tell them to do it in a dropper so that they don't taste it either. Okay. So some of the things, so make sure you look at iron in your pharmacology stuff and review that. In severe cases of iron deficiency, then blood transfusions may be needed. Why blood transfusion? If blood has, and so, but that's again your last step. Alright, the rest of it is on iron deficiency. You can read through it. The nursing part. Let me cover sickle cell anemia. Sickle cell anemia, here also you have a decrease in RBC, right, overall. But what's the patho here? It's a genetic. It's a genetic component, right? So genetic issue here where you have basically abnormal shape or sickling of the red blood cells. So when that happens, the red blood cells are not able to carry adequate amounts of oxygen then to the cell. So you have sickle cell anemia. Okay. Sickle cell anemia, usually there's a history in the family. They're doing tests when the child is born. Okay, they've already done some genetic tests prior to that, and to really find out what's causing, how do we need to treat this child based on what's going on. So overall here, if the child has sickle cell anemia from birth, this child is now exposed to low oxygen levels for a long period of time. So it can affect the entire growth and development in this child overall. Okay, so growth retardation, chronic anemia, we're talking about hemoglobin as low as 6, we're seeing children with 5, 4. I'm trying not to wait till then, but try to get all these things done, but really, what do you think the primary treatment is for sickle cell anemia? Blood transfusion. We're not even really messing with some of these supplements we give them, but it's really the transfusion for these kids. So children, when they're in a sickle cell crisis, make sure you read over that. That's really when you see the patients in the hospital. A sickle cell crisis. Well, what is a sickle cell crisis? There are different things that can trigger a sickle cell crisis. So here you basically have a decrease in circulation, a significant decrease in circulation. Okay? So it tends to be very painful. So you have basically vasodilation that's occurring, clumping, clustering of these abnormal red blood cells, so that circulation is affected. The child is going to have severe pain. A lot of times they come in with pain, not only in their periphery, right, hands and legs, but what we call an acute chest syndrome, ACS, acute chest syndrome. They'll say, my chest hurts, and they usually come in like this, and you think they're choking, but it's really, they're in a lot of pain, they're having a difficult time breathing. All right? Sickle cell crisis. So when they come in, usually it's in the ER. To see them in the clinic, now we tell them, you need to go to the ER very quickly. In the ER, what needs to be done is bolus to improve circulation as quickly as possible, so you can prevent some of those inflammatory responses that's occurring already, right? The redness, inflammation, the pain, etc. So the child is usually given morphine, and the morphine does a couple of different things. One, it helps pain, right? Helps the child, but it also helps their anxiety. Once the child is calm, what happens when you have a panic attack, you're anxious, or you can't breathe? What happens to your heart rate? It goes up. It goes up. Now the heart's working faster, blood pressure goes up. Man, you got a cascade of things that's happening that's going to have a negative effect on that child. So number one is to calm the child down. Decrease the pain. So usually, and we sometimes have a hard time getting IVs on these patients because their cells, their vessels are so small, right? And so a lot of times we do a scalp vein, have to get a larger vein so that we can at least get some pain medicine. And the other thing is fluid. Lots of IV fluid. What does fluid do to circulation? Okay? with that stasis, the child can develop a line. And so what the fluid does is help to really push the cells through much better, increases circulation and improves circulation. So lots of fluid, IV fluid, and then morphine. One of the first things that we do for this patient. If they're coming in like this, we don't even need to order. We're putting an oxygen on them, either nasal cannula or an oxygen mask, because we already know, right? Their circulation is, and the oxygen is also going down. If you do a pulse ox on these patients, a lot of times it's like 90s, 92, 93. Okay, so we start them on oxygen, but the key is the morphine. Because that morphine helps them to calm down, get their anxiety down, get their heart rate down, and guess what? Now we can help with the circulation of fluid and things like that. Okay? So vaso-occlusive crisis is the main thing that you need to know. The long-term effects. I've seen babies that are born within a couple of months, they have strokes because of sickle cell anemia. All right? The vaso-occlusion that occurs in the brain, in the heart, in the liver, all over, so they can have ischemic attacks almost anywhere. All right? So they're at higher risk for stroke, higher risk for organ damage, all of these things. Okay? So this visual gives you all of the systems that's affected in these patients. Diagnostics, like I mentioned, if there's history in the family, or if we really don't have a good history on that child, at birth they do a significant amount of tests that are done, right? So along with the newborn screening, the sickle deck that's done, hemoglobin electrophoresis really is the more specific test to tell you if this child has sickle cell. And somebody had posted on that as well, right? On the discussion post. One of the things that's done is hydroxyurea. Make sure you read about that from your farm. Okay? Hydroxyurea. Hydroxyurea, what it does in infants or newborns is it helps to keep hemoglobin S in circulation in larger amounts. What they found is in newborns where they have the fetal hemoglobin, the fetal hemoglobin has, we see less signs and symptoms in children whose hemoglobin, infants, the hemoglobin is higher. Okay? And so what hydroxyurea is, helps to contain or maintain fetal hemoglobin in circulation. So one of the primary meds that's given for children who are diagnosed, or babies that are diagnosed with sickle cell is hydroxyurea. So make sure you read on that as well. Alright. What's one of the last things that's done along with blood transfusions that may be frequently done? It's really a stem cell transplant for these patients. Okay. Alright, so the nursing care related to all the things that this child can experience. Right? That's what this list is. Medical as well as nursing care related to all of this. The child is at higher risk for infection, thrombosis formation, a lot of other things, a lot of pain. All right, do we apply heat or cold on these patients? Heat. Why?
Vasodilation.
Okay, so heat application causes vasodilation. And what we want is to improve circulation in these patients, correct? What does cold application do?
Vasoconstriction.
Vasoconstriction. And remember, they already have vasoconstriction because of the pumping in the body. So you don't want to put anything cold on them. So in their extremities, a lot of times you pack them in warm towels, warm blankets to help them with circulation. Okay? Especially if they're having a lot of pain and swelling in their extremities. And of course, this is not the time that you want them running around, and believe me, they're not going to want to be running around, right? They're not feeling good, they can hardly breathe, complete bed rest during this time. So those are all things that we kind of know there. This is what I was talking about, the acute chest syndrome, ACS. Alright, that's where they complain that they're having difficulty breathing, their chest hurts, in the vaso-occlusive crisis, ACS. Alright, moving from the anemia to hemophilia. Hemostasis is just a general term.